Willkommen to Amsterdam. So welcome everybody to ECTRIMS 2022, and I'd like to introduce myself. My name is David Baker. I'm my lovely host.
Thank you, David. So my name is Dr. Shamli Nyanapava, neurology consultant. I'm sure you've met both of us on previous Hangouts, but it's wonderful to come back to the Hangout. So thank you for all of you who have actually replied to our survey. It's given us a good idea of what to really look out for in ECTRIMS in Amsterdam. I'd also like to thank our funders, Novartis, for funding this as an education grant. Just to say, it's not sponsored by them. So what's going to happen, David?
Well, we've got an action-packed bit of time for you. So the first thing I'd like to say is live. So if you do have a question, you can go into the comments and ask a question, and hopefully we can see that and answer it along. But if you can't and you're watching it later, please still give us a question, and we'll come back to you, and we'll probably do another kind of bit of a stream so we can answer all your questions.
So the layout of the Hangout this afternoon is going to be starting off with the definitions blurb, as well as then moving on to the actual scientific topics. We'll be looking at cutting-edge stuff like remyelination and biomarkers, then moving on to clinical trials, because that's what most of us are here for, and then finishing off with quality of life in MS and late breaking. So let's start with the definitions.
Okay, so what's the first one then?
Thank you. So let's start with the first. It's CIS, which stands for Clinically Isolated Syndrome.
That's the first kind of clinical episode.
Yeah, exactly. But then we've got a newer one called RIS, or Radiologically Isolated Syndrome.
So that's when they put you under a scanner and they see something that they think is MS, and then maybe a bit later it does become MS.
Yeah, you may or may not develop MS after receiving a diagnosis of RIS. That's what makes it tricky to manage. And then a newer term, which a lot of you may not have heard of, called PIRA, which stands for Progression Independent of Relapse Activity, and biomarker. So biomarker is anything that you can actually measure, and there are also new biomarker technologies, and the two which I'll be focusing on is data on the Quanterix technology and also the more recent SomaScan. And then going back to clinical definitions, so NEDA stands for No Evidence of Disease Activity, and remyelination.
So what's that mean? Well, I guess I'm going to tell you the first little bit of stuff of what I've been looking at. In terms of remyelination, I guess it's the thing that you want to know about the most, and it's basically how we repair things. And I hate to say, of course, it's in experimental situations. So we've had obviously quite a few presentations on different elements of remyelination, but I probably would say that most of that isn't really ready for prime time. Now, there is some suggestion with the sphingosine-1 phosphate modulators, like the Siponimod, Fingolimod, Ozanimod, and Personalised. And there is some suggestion that they can affect oligodendrocyte biology, and it may well be that there is some repair potential. But I guess at the moment we don't really know. Now, in terms of kind of moving on to prime time, you may have heard of a drug called clemastine. And this, I think, is an antihistamine type drug.
Yeah.
And it's kind of been tested to see if it helps kind of slowing down the visual system loss. And there's been a study in San Francisco, and I think what we've been told is they're actually expanding that to go for a new trial in starting in the States, but it's also got a site in France, and also I understand there is a site in the UK. So that's about to start. So obviously, I think one thing that we kind of suffer from this time is that clearly we've had the COVID pandemic and also the situation in the Ukraine, which has kind of hampered really the clinical trial development. But we'll plough on. Now, in terms of the other thing that you're clearly interested in is progression progression.
Yes.
And I guess the question is I can't give you a good answer of where we are with new definitive drugs for progression, but we're going there, certainly. And I just wanted to draw attention to one of the studies where we actually are having some success, and there's a kind of another follow-on study with a drug called Ibudilast, which is phosphorase diestrase inhibitor, but that doesn't matter. But again, it's been showing that it can actually impact on these expanding lesions, which we think are one of the underlying features of progression, and this agent can inhibit it. Now, of course, in terms of progression, we have to kind of try it and see how we look at the clinical profile, but that takes a long time. So one of the ways we can try and do it a bit quicker is to look for biomarkers. And we have had a bit of interest, I think, this time. We know about neurofilaments. These are these things that are inside nerves, but there's this other molecule called glial fibrillary acidic protein, which is a thing inside astrocytes. These are kind of star-shaped cells that are in your brain, and they help support the nerves. They help support the blood-brain barrier, and so it's interesting that when people look in the blood of people, they can see evidence of this GFAP protein, and it seems that this is a reasonably good marker to help distinguish between what is PIRA and non-PIRA. And of course, that's important because PIRA is the progression that's independent of the relapses, and that's really what we want to target.
Coming back to that, David, I mean, the PIRA definition, it's difficult to really say who's having progression that's not related to a relapse.
Yeah.
And this is where these biomarkers are quite useful, aren't they?
Yeah.
So for our audience, you can see these two box and whisker diagrams.
Yeah.
The first one in the middle is GFAP, and the second one is NFL. So would you like to tell us a bit more about what this shows?
Well, I mean, so they're looking at the different types, and essentially one goes up, and you can see the brown one, and essentially it distinguishes it from the blue one. So it tells you that you can get an indication of whether you've got this PIRA or you haven't got the PIRA. And the numbers at the top is kind of the statistical significance. Okay. And so you can see on the one on the right, which is neurofilament, this is a nerve protein, that it's not really significantly different, whereas the other one is really significantly different as long as your arm. I mean...
Yeah, so this really tells us that, I mean, this is a problem with neurofilament light chain, that it's a great indicator of relapse-related neuronal loss, but when you come to progression, it is not that good because a value of 0.067 is technically non-significant, isn't it?
Yeah. But then you look at the other one, and it clearly, you can start to see there is a difference. And of course, if that is robust, and there were a number of studies on it, it kind of tells you maybe we've got a handle of looking at this measurement, and of course that's going to be tell us things much quicker than waiting for a clinical trial, which is going to take a long time. So that's kind of one of the encouraging features, and it was kind of one of the newer things that came on.
So one of the other biomarkers which was presented is the free kappa light chains, and this is something which is now very topical because it may potentially replace the oligoclonal bands. So what they demonstrated was that if you had elevated CSF kappa-free light chains, your probability of remaining cis, i.e. just with the first clinical event, drops substantially. So I think this is quite informative. Also, if you were more likely to have oligoclonal bands if you're kappa-free light chains positive as well. So technically, it can replace the oligoclonal bands.
Okay, so just for those at home thinking, what's a kappa chain? So the arm of an antibody molecule. It's got two arms, and it's like made up of what we call a heavy chain, which is a big bit, and a small bit, which is the light chain. And the light chain, there are two types, one called lambda, the other one called kappa. And what can happen is that antibody molecule can kind of break apart, and then the kappa molecules can float around, and we can pick that up. So that's what that means.
Very interesting, isn't it? So moving on to some issues with this is that although kappa light chains is technically ready to go, the problem is there seems to be a lot of variability of what's been already published, particularly when you're looking for something which is positive or negative. You need to have a cutoff value.
Yeah.
And the studies which we have reviewed or as part of a consortium and is now ready to be, is in press in Multiple Sclerosis Journal by Harold Hagen, shows that the cutoff values are wide. And so that definitely needs to be sorted out before this can become prime time. So moving on to new technology, we've got what's called the SomaLogic or Soma scan. And what these are aptamers. And David, you're going to call me up on this, but
Yeah.
aptamers are DNA-based binding regions which can have sidearms to the DNA protein, which is then specific for the analyte you want to capture. And so you can really design as many aptamers as you want as the peptides which we're looking at. And so this is really outstanding work from Bibiani Belakova's team, where they showed that in looking at the placebo arms of progressive MS trials, so these are people who progressed in those placebo arms, they found, interestingly, that there were huge readouts for inflammation and fibrosis-related pathways. Now, this is really interesting, isn't it? Because we often talk about progression as a neurodegenerative thing, but clearly we are seeing inflammation also being quite active in that. So maybe the two aren't so dichotomized as we used to think.
Yeah, I mean, I think there are also different types of inflammation, and some of it is driven by the kind of adaptive immune system. They're the T and the B cells, and then there are some bits that are driven by the what we call the innate immune system, which are like macrophages. And actually, one of the kind of new drugs that is starting to surface, and we'll hear a lot more in probably a year or two time once the clinical trials are, but they're the next ones that Chamberlain's going to tell you about.
So a lot of you were interested in, and we did listen, so you all wanted to know about BTKIs. And unfortunately, because of the pandemic, the phase 3 trials are not ready to report. But at ECTRIMS this year, what they did have is the extension of the phase 2B studies from relapsing remitting MS for tolbrutinib. And what it shows, as no surprise, is sustained reduction in annualized relapse rate, and on follow-up, the EDSS remained stable.
And that's kind of in the kind of realm that we see with the CD20 deleters. So it's quite encouraging. And of course, what we are hoping, of course, is that it will also affect kind of this kind of PIRA, this progression.
Yeah.
And there are studies that are involved. And this is where the new action's really going to be in terms of MS in the future. And it's like, who gets there first? And it's very interesting that, you know, there are a lot of different agents that are in the pipeline, and some more in the pipeline. There are, I think, 4 in late-stage development. But what we're also seeing is there are differences within them. And so I guess that's where the war will be. Some of them seem to get into the central nervous system better than others, and some of them you have to take more frequently than others. So it's going to be an interesting one.
This is technically very different drugs. So although you've got oral treatments, one is given 60 milligram, so different dosing is being produced between the different drugs. And also you've got the CNS target occupancy, which seems to be very high. And we haven't actually put the details of what these drugs are for a reason, because I think this work definitely needs to be replicated. But you can see a spectrum. There's one even which is only 18% in the brain. So do you think that is of any use?
Well, I think it depends on where you think these drugs work, and I think clearly we know that some of them work in the blood to stop those lesions forming, and maybe if you do that very well, that actually stops the real PIRA really. So the jury's out. We'll just have to wait and see what happens in the clinical trials, and hopefully you can invite us back sometime, and we'll tell you all about that when they arrive.
Yeah. So moving on to pregnancy, which also was an interesting discussion topic. But what was interesting and what I found interesting was the data showing that if you had a pregnancy, by including everybody below an EDSS of 2.5 and then looked at pregnancy after that, the time taken to reach a hard EDSS point of 3, i.e. starting to show points of disability, seemed to depend on your pregnancy count. So it didn't matter what age you were, as the number of pregnancies increased, the time taken to reach a reversible EDSS score 3 started to increase. So very interesting stuff about the protective effects of pregnancy in terms of disability progression. So it's not all about drugs.
Yeah, and to be honest, historically, pregnancy was probably the first DMT to some extent, because it did drop the relapse rate. So of course we have to think about what treatments we can do, and also we want to think about what are the causes. And of course, the thing that we've all been hearing about an awful lot of is Epstein-Barr Virus, and of course it has been flavour of the meeting again. So there's been a lot of information suggesting that there may be a link between MS and the EBV load, and also suggestions about how it may trigger an autoimmune response. And I would say, of course, is that what I could see from some of the presentations, there is kind of a lack of consistency in what the target may be. So we've had at least 3 different targets that EBV can target 3 different proteins in the brain. So,
what do you mean by that? Is it targeting on B cells or on how they enter, or?
So what they've been showing is that an immune response to parts of the EBV can cross-react to certain brain proteins, but when they've done different studies, they haven't pulled out the same one. And you would think if it was really consistent, they would pull out the same one. So I think the kind of the thing is out. Now, of course, the question is how do we move on and how do we treat from that? And actually today there's been some studies showing that if you kind of use antibodies against EBV, you can stop mice from getting kind of EBV-related cancers. Now, that leads me on to the next kind of bit, because it's a thing that we've been interested in, is whether there are viruses that are targeted in causes of multiple sclerosis. And we have had some more studies with this antibody called Remyelination, and that targets a human endogenous retrovirus. And some people have argued that this may be a target of the immune response. And we have seen some trials, and it was shown really that it didn't really block the relapsing element. And so what was reported...
This is the Protect MS study, yeah?
Yeah.
By, is it Frederick Peel?
Yeah.
Is it? Okay, I remember that.
From Sweden.
Yeah.
And so what they've done is they've combined this antibody against the virus with an antibody against the B cells to get rid of the relapses. And sure enough, what they found was there wasn't any effect on the relapse rate. But I would also argue that at the moment, I didn't think the results were that great. And of course, it says to me that we've got to be very careful about our trials, because it may be that the viruses are very good, but the question is, can the antibodies get to them in sufficient numbers? And they did show it can get in the brain, but it's a word of warning, is that just because we can make an antibody to something, it doesn't mean to say it will work, because it can't get in the brain very well, and we might need a chemical or a different approach to it. So that's why I kind of mentioned that study.
So very interesting. Now moving on, obviously personalized interval dosing is a major topic.
What do you mean by that?
So standard methodology in how a clinical trial determines how dosing happened. So for example, if we take Natalizumab, it was originally given every 4 weekly. Now the problem is that this raises the question: do we need to give it every 4 weekly, particularly when there's an increased risk of PML with preventing immune cells from getting into the CNS? So if you have that, why not, peter it out and see if everyone needs to get the same dose. So this is an attempt to then go back after you've licensed your product and look at all the safety profiles and say that actually you have very high levels of the drug in your system and you don't really need to be on the same dose. So what you do is you extend the dosing of the drug. You can do it other ways, which is to reduce how many milligrams per kilogram you receive of the drug. But the easiest way is to just let it run through and then wait. So Zoe Van Kempen talked about Natalizumab, which is where she's talked about dose as well as timing of the dosing. And what she showed was that if you do look at all the published data, that there is like the same efficacy with extended interval dosing as well as the original dosing of 4 weekly. So extended interval dosing, for those of you who haven't come across, is a 6 weekly dosing of it. But I think it probably can be extended up to 8 weeks if you can actually measure Natalizumab levels. And I went to a separate industry session where there are now machines which can give real-time readouts of drug levels, particularly that of Natalizumab, which are in development. So it's really...
So that's personalised, isn't it?
Yes, it's very much personalised, and I think this is the direction we're moving on.
And I think the other thing that we should just say is, obviously, part of the advantage of that thing is it's been indicated that really reduces the risk of that PML, which is that virus that causes a kind of brain condition. So that's really good news.
She also presented some interesting finding about Ocrelizumab, which is something I didn't know about. I don't know if you knew, but actually even up to 8 months, there are still, as far as Ocrelizumab is concerned, measurable concentration in people. I actually thought it's just the effect of the drug was that long-lasting. So this really does make it difficult to tailor Ocrelizumab in the levels you're going to use. So it would be nice to have these drug levels available so that you can make that decisions, because you've been a proponent of looking at B cells, repopulation, to see if Ocrelizumab can be petered out. But it may be nice to get these drug levels as well on top of that.
Yeah, and I think that was obviously another feature. I don't want to really labour it because we're all bored of COVID-19, but it kind of came out with COVID-19 is maybe you don't have to dose quite as often as every 6 months to still have kind of benefit, and that maybe help you get a better vaccine response. But again, the data's also appearing actually maybe not just looking at the B cells, but looking at the drug levels is really the key to that. So again, it's another bit of evidence saying personalised dosing is useful, and probably that's the way forward.
So I think she finished the talk just showing all the current studies which are active. So hopefully at the next ECTRIMS or AAN, some of these will start to report. So there's 2 on Natalizumab and 3 on Ocrelizumab. So there's really a lot of interest in getting these studies going and getting the answers that we need.
Yeah, made me happy. I wanted to do this for a long time.
Moving on, we're going to look at some real-world evidence that's been very topical this year.
Yeah.
MS Base has been very active, and there's been a lot of platforms and posters
What's
from the
MS Base?
MS Base team. So MS Base is they're a group of like-minded clinicians who've got together and created a database so that we can actually look at efficacy data, but also look to see what patient characteristics seem to lead to one outcome versus the next. So it is complicated stuff to look at real-world data using this very complex statistical methodology rather than looking at randomized controlled trials. Randomized controlled trials, you are randomly assigned to either the treatment or the placebo, and therefore you kind of assume that everyone's been fairly assigned. But when you're picking people just randomly from your database, you need to make sure that there isn't any bias in it, and that's the issue with observational data. If you pick it out and try and get something useful in terms of treatment efficacy, rather than a randomized control trial which controls for everything from the outset and prospectively measures it. So there was two presentations which were presented, which I'll come to, but the Queen Square group also presented their what I call a single center experience of their drugs. So essentially they looked at the effectiveness of different disease-modifying treatments. The ones they compared were dimethyl fumarate, Fingolimod, glatiramer acetate, Natalizumab, and Ocrelizumab. They looked at relapse rates, EDSS, MRI activity, and NEDA3. Now, just to say that this was, they had to be on the DMT for at least 24 months, or until the DMT was discontinued. And what they looked at is relapses at year 1 and 2, as well as MRI data, as well as NEDA3 data. Just to say, the groups are imbalanced. So in terms of age, they're well matched, but in terms of N number, you had like massive groups in the dimethyl fumarate, glatiramer, and then you had much smaller groups in the Ocrelizumab, Fingolimod, and Natalizumab arms. Also, one thing I picked up was that the EDSS scores differed differently between the treatment arms. So, for example, DMF EDSS score, not surprisingly, was at 2, but whereas the Natalizumab, the median EDSS score in a sample size of 177 was 6. So
but you'd expect that it's not maybe that big, but you'd expect it just because
how it's licensed.
Generally with Natalizumab, you've failed something in the past and maybe you've accumulated a bit of disability.
No, exactly. So it does make it technically difficult, though, to compare the data. But what they did find was that if you looked at Ocrelizumab, as opposed to every other drug, at year 2, it had less patients with relapses compared to, say, for example, DMF and even Natalizumab. So take what you may from that data, but it is kind of interesting. If we move on to EDSS score, I have to say, I'm not sure, but it seems like nobody's doing well on any of the drugs, really, to tell you the truth.
Really?
But I don't see the box and whisker plots are wide. But maybe if they expand this to year 3 and year 4, we may start to see this starting to change. So it may be that either some get worse whilst others improve. So it'll be interesting to see what their follow-up analysis will be. And so this is their basically Kaplan-Meier plot, and what they show is that if we have a look, Ocrelizumab is the purple arm, really in terms of NEDA3, time to NEDA3 loss at 24 months. The Ocrelizumab group are doing better because NEDA3 is a composite measure of MRI and clinical activity. So everything I've shown you here, if you put it all together in one, this is what you get. So as it creeps towards 24 months, you find the others start to lose their NEDA3 potential. So you've got their DMF and then you've got Fingolimod, and you've got Glitterimab right at the bottom in the yellow, which starts to lose its NEDA3 status quite significantly in the patient group.
So while we're talking about real-life data, I just wanted to maybe say the trial data with cladribine was kind of replicated, and it kind of showed that basically it worked very well, and there were only a few patients that had to switch onto something else because they obviously failed. I think it was about less than 15%.
I think if I remember, 80% really worked.
Yeah.
And so I think when you're dealing with small numbers, it is a bit tricky to get any
but
granularity.
The answer that we didn't get, which is what we wanted, is what you do after 4 years, and that wasn't clear.
Yes.
And I think that's something where we still really need to know what to do, whether you stop, redose, switch, or just watch and wait. And I think there's kind of evidence that different people prefer different things. So that's something that obviously we will hopefully hear in later meetings. So off we go in terms of real-world data. Tell me more.
So let's move on to the MS-based guys. So the first one, which was of interest to everybody really, is the comparative effectiveness of AHSCT versus Fingolimod, Ocrelizumab, and Natalizumab in relapsing remitting MS. So the problem here is where does the AHSCT data come from? And so many of the AHSCT trial groups contributed the AHSCT data to make up the sample size. And then the MS base amalgamated the rest of it to provide the rest of the drugs as well. Or that's how I understood it. And it needed to be first exposure to AHSCT, Natalizumab or Ocrelizumab or Fingolimod, and they couldn't have exposure to alemtuzumab or participated in a randomized control trial within the 10 years prior to starting. And if we look at the actual procedures which were used, these were the AHSCT procedures. And then you've got there the doses of Natalizumab, Ocrelizumab, and Fingolimod, which was used. So we do know that there will be some variability in the AHSCT procedures. So what was disappointing is that in terms of relapses, Ocrelizumab seemed to do slightly, or AHSCT was no different to Ocrelizumab, which is a bit bizarre, but I have to say that the follow-up is only 3 years, so I don't think it's early. It's too early, isn't it, to really show a difference. In terms of disability outcomes, similarly, there was no difference between AHSCT versus Ocrelizumab. So really, the conclusion which was made in the talk was that it does. This is data which I haven't shown you, but it was AHSCT was superior to the other drugs looked at, but it wasn't. Even with a shorter follow-up, it didn't. It seemed quite similar to Ocrelizumab.
Yeah, and there was another presentation where they looked at alemtuzumab and cladribine, and again, there was no added benefit from stem cell transplantation over those treatments.
So I mean, what's going wrong here?
Well, I think what they did is they tried to compare like with like, and what we've seen in the kind of preliminary studies is that the very, very select group of patients that are getting these AC stem cells, and they're doing very well. But it may be that if you kind of do a proper randomization thing, then maybe it's not that much better than you can achieve with standard drugs. And of course, it's the risk that people are exposed to, because I think sometimes you do tend to see more infection risk, etc. Certainly early on.
Yeah.
So it's kind of the risk benefit.
I mean, as far as this study was concerned, the authors did point out some limitations, some of which we already have discussed, which is that these cohorts came from everywhere. Yeah. So we're not really looking at one single cohort from one center. Also, there's no randomization. You did what was called propensity matching. So you look to control for biases.
So I think it'd be interesting to see when these are really published, and I'm sure you at home will, in your kind of groups, will kind of have your opinions about this. But data's data, and that's what it is, you know.
So moving on, what we had is the early treatment contingent.
Yeah.
And we are very much supporters. I think delaying treatment in MS, guys, is a bad idea because the outcomes are best when treated early. And there is a hypothesis, or well, a kind of a movement to doing early treatment using very highly active drugs. So you've got the induction treatments such as alemtuzumab, cladribine, and in the past it was mitoxantrone, whereas you've got the continuous intensive therapies such as Natalizumab, Fingolimod, and Ocrelizumab. And interestingly, what we still have is that even if you use these highly active drugs early on, that many of them don't have sustained NEDA3 over time. So we're not there yet, but it is something which we're working towards as far as treatments are concerned in MS. So one of the other interesting things which was presented is the 10-year follow-up to mitoxantrone.
Okay.
I mean, is there anyone still using mitoxantrone? But it is nice to see that data, and surprisingly, it seems like majority of the patients did do well. So many didn't need to change. So on the far right, what you can see is the relapses, and you see that right at the start, they're high in terms of relapses. The box of Whisker plot is high, and then it goes down to negligible, and then also is that the disability is stable.
That's good.
So, I mean, this is amazing, and this is what we used to use for what we call transitional patients, because we didn't want them to go from relapsing remitting to secondary progressive MS. So it's nice to see the long-term outcome data of this drug. So, you know, watch this space. There might be a resurgence of mitoxantrone in the future.
Interesting.
I mean, I'm not going to say anything about the side effects of mitoxantrone, which a lot of us know about.
Yeah.
So these are the options which people have, which is that you can either go and choose induction treatments, or you basically do very highly active treatments as continuous intensive therapies. So what you can think about is what would you do after you've given that highly active drug. The options are you just stay on it. It just seems easy enough. Or if you want to, you can switch to another high efficacy DMT, or you de-escalate to a less potent DMT, which really is an interesting concept. Or essentially you do extended dosing to really abrogate the PML risk, or discontinue treatment completely. What was interesting was also discussed is why would you de-escalate somebody? And this is something which is a lot of clinicians are thinking of as their patients get older.
Yeah.
So it may be that it may be patient preference, or JCV virus antibody seroconversion, whether they move out of centers. And last but not least, I think equally important is poor venous access. You know, once you start cannulating every vein, you're going to run out of veins, isn't it? So what was suggested by Manuel Warbon is to really think about what you would do in patients. And what she has, in her mind, decided is to split between those with high lesion load at onset, including spinal cord improvement and high disease activity pre-high efficacy DMT, and then those with moderate lesion load. So, so both can stay the course. In the high lesion load, you may or may not consider extended dosing because it may reactivate their disease. But in the moderate lesion load and at the early onset, you may actually want to do that, or you may you may not, in those with moderate lesion load, may not want to switch to any other high efficacy drugs. So what you probably wouldn't do in either is discontinue the DMT.
Yeah, and I think there was a few papers suggesting if you have very highly active disease, you were at more risk of showing disease activity. So it kind of makes sense.
So moving on, David.
So I guess the question is of course, we've got lots of different treatments. We've got progressive treatments, and we want to kind of know how do they work. And so one of the interesting things is, of course, is how does a B-cell depleting therapy work? And there were some studies where they were looking at MRI, and they couldn't really see an inhibition of the lesions. And I think there was another study where they looked for B cells in the brain.
This is smouldering lesions, so okay.
Yeah, and the conclusion was maybe there's not many B cells in there for them to target, so maybe it's not that important. I would argue maybe you don't need that many to be important from what I've seen in the
So
past.
are we talking about using anti-CD20 in progressive MS?
Yes,
or is
yes,
that what this
yes.
data was showing?
It's all about that. And I guess the question again is how much of the antibody gets into the brain. So that's kind of always a kind of a thing. It also potentially gives us options to develop things further if brain penetration turns out to be the key. And kind of one of the interesting things, of course, is when you have long-term B-cell therapy, that your antibody levels can drop, and it potentially has been thought that's a risk factor for infection.
Yeah.
And it was really interesting when they presented the kind of 7-year data that the kind of antibody levels seemed to stabilize. It didn't just keep dropping and dropping and dropping.
This is a Curios study?
No, that was a different study. That was
right.
the extension from the Ocrelizumab study, I think.
The Obo...
yeah,
We'll
one
have
of them.
to check
And
up on that.
then there are other studies, and again, it all boils down to whether the antibodies all work the same. And clearly they work because they deplete B cells, but there was some interesting studies looking at Ofatumumab and looking at the effect on...
that's the Curios study.
Yeah. And they were looking at the effect on vaccine responses to SARS-CoV-2. And what we know, of course, is that the anti-CD20s really dropped the B-cell response. But it was kind of interesting that although the response was dropped, it was still detectable in it was very evident that they were still present, and there was also the studies suggesting that maybe the kind of B cells in the lymph nodes aren't cleared as much, so there may be subtle differences, and that's important.
Right. Well, thank you for that. So moving on, so to some, let's switch the pace. This is looking at quality of life. There was some interesting work being done by investigators, and I'll go through this quite quickly, which is that one of the things which of interest to physicians as well as patients is what determines fatigue. And obviously what they confirmed was that if you've got more T2 lesions and if you've got reduction in brain volume and also grey matter volume and white matter volume, you are more likely to be fatigued. What was also found was that in patients who even independently from fatigue, they had worse motor and cognitive short-term and dual task performance, single task and dual task performance. So you were seeing the two, but this seemed to happen. They did find that the structural and functional MRI abnormalities tend to be more in the cortical and subcortical networks. So I think we may be going towards explaining in more detail what fatigue is in MS, but it will be interesting to see some of these parameters now being used to in clinical trials in fatigue. Another presentation which I found to be quite interesting, the critical factors which were associated with low quality of life. And in this study, what they reported was that gender, so particularly male gender, tended to report low quality of life in MS. as well as depression and stress. So I think it is worth thinking about these carefully if you're a sufferer with MS, so that you do target these things in your life and cell. You can't do anything about being male, but you definitely can do something about depression and stress. So moving on, there is some stuff about whether disabling relapses actually lead to worse outcome. And it was shown that there is a higher risk of disability accumulation in people with non-disabling relapses compared to those who weren't experiencing any relapses early in their MS. Not surprisingly, in those with who had disabling relapses, they tended to be worse than those who experienced non-disabling relapses. But it doesn't, in their data at least, there didn't seem to be an effect with high efficacy DMTs. So a bit strange there, but I'm sure that would be interesting to see, because this is the problem when you're doing these real life analysis. Sometimes it's not really head-to-head comparisons of, and trying to do disease-modifying treatment comparisons is very difficult.
This is a first, the world first now, I think.
Yeah.
Generally, obviously, you get treated with with drugs after you've got MS, but this time we actually heard of treatment before people would be diagnosed with MS.
So this was something really topical back in the day, isn't it? Whether we should treat radiologically isolated syndrome or not. And I don't know, I mean, you attended the session, so what did you actually find?
So I think what was shown, of course, is that there was a study looking at people who'd got radio-isolated syndrome, and that was what occurs, possibly, a few years before you would be getting a kind of a diagnosis of MS. So the question was, if we treat people at this stage, would you convert to MS? And I think the study was 96 weeks, that's about 2 years. And they used Tecfidera, dimethyl fumarate, and the results were quite startling, I suppose. I mean, there was a reduction, about 80% reduction in the chance that you would actually convert to multiple sclerosis. Now, maybe that's not that surprising, because when you look histologically in these tissues, it looks like MS, but it kind of tells you that you could potentially treat early and so it shows you it's possible. Whether this is the route we'll go in the future is going to be interesting. But
this is very interesting data, because it does show that if you treat RIS, you can in fact reduce the evolution of new MRI lesions, and that's important.
Yeah.
But really, we know that not every radiologically isolated syndrome becomes and has an MS relapse and evolves into clinical MS. So
that's for you guys to really work out what the kind of ethical bits is. But for me, I'm a scientist. It kind of shows you the potential, and it kind of tells you that the processes are occurring much earlier on, and that you potentially can do something about it.
Then some more interesting, very hard to really say what we think about these things, but there was a non-inferiority study of Rituximab versus Ocrelizumab in relapsing remitting MS. Why do this study?
So Ocrelizumab is a CD20 B-cell depleter. Rituximab is also a CD20 depleter. So this study, what they mean non-inferior, you do the study to show if they're not worse than each other. So that's what non-inferiority. You don't do it to say it's superior or inferior, to say they're not worse than each other. So this is the study. Why do that? Well, in certain countries, Rituximab is used off-label. Clearly, the Ocrelizumab is the licensed agent. Question is, are they really different? And you might say, no, they're not different. Well, maybe you have to think again.
So again, this is a statistical technique called propensity matching, and what you can see is that patients were matched for age, sex, MS duration, EDSS, and the list goes on. And then they were censored for other variables as well. So that's to make sure that you're not really getting noise entering into the analysis. And as David explained, this is the statistical approach for non-inferiority. So if you look to the left, if you move towards the left, you favor Rituximab. If you move to the right, you favor Ocrelizumab. And so at that point, you become inferior as far as Rituximab is concerned. And that gap between where you're superior and inferior is the non-inferiority score. But once you go past that, then you're in trouble. Now, what did we see? Well, what we saw was that that exactly happened, because it seemed like the actual relapse rate went way into the Ocrelizumab side. So
suggesting that Rituximab is inferior to Ocrelizumab, and of course then you've got to ask the question why. And I think one well, you know, with Ocrelizumab we've got standard interval dosing and standard dose, whereas with Rituximab, because it's off-label, you can use it in different people and also different doses. But they did say that they even if they looked at the standard high 1,000 milligram, that it still seemed to hold out. So that's interesting. But there is biology, because Ocrelizumab was developed to be more B-cell depleting than Rituximab.
Yeah.
So it's interesting.
I mean, this is a balance between a drug which is really available off-label. We're talking about Rituximab. So for countries who don't have access to Ocrelizumab, it is cheap.
Yeah.
And so it gives them access to something when they wouldn't necessarily have access to the more expensive B-cell treatments.
But this was done from like one of these, you know, databases. Again, they did tell us that a study is ongoing in Sweden, so a properly controlled one. So you'll get the answer. You know, the data will be what it is.
Very good. So another one, which was also equally controversial, was comparing the effectiveness of AHSCT to highly effective DMT, such as Natalizumab, in controlling disability in progressive MS, i.e. SPMS and PPMS. And again, really, if you looked at relapse outcomes, the same. And it doesn't matter which way you looked at, it was very similar. So, and also they looked for confounding. So they looked at Hodge-Lehmann score as well.
What's that?
Well, it's for confounders. So if you've got confounders in your analysis, you need to look at these. These are like all sorts of sensitivity analysis which you have to perform. But that's what they found. If we move on to disability outcomes, again, I'm not seeing much difference here at 6-month confirmed disability worsening or improvement. So not quite sure what's going on there.
I'm sure the internet will be
buzzing.
Yes.
Yeah. Although I do have to say that there are a number of study limitations. Again, like previous real-life data, I would say that there's, again, lack of randomization to consider. The cohort sizes were limited by the HSCT arm, really, because they're small studies. And, again, it's multicentric cohort. So there are things to consider. We don't have MRI data.
Yeah.
And we know how impressive MRI data is for HSCT, do we not? I mean, we don't have that data to compare. Yeah. So the conclusion from that study was that in those with progressive MS, advanced disability, and low pre-treatment relapse activity enriched with patients with recent disability, HSCT was not superior to Natalizumab.
Yeah, well, the data's what the data is, and you know, we'll just have to see how things pan out in the future. But you know, it does tell you perhaps that HSCT doesn't have to be the panacea that many people think it is. You know, we just have to do the studies, and the data's what it is. And at the moment, it's saying, you know, it isn't that much better.
Yeah.
So you know, think about that when you know, what
Yeah.
we don't want people to do is, you know, use
Yeah.
their life savings for things that aren't going to benefit them really.
Yeah, exactly. And but you know, I mean, these were some very controversial, late-breaking abstracts.
Yeah.
I have to say, and I think people would be dissecting this for a number of weeks and days to
Yeah.
come. You know, so we will see. So that brings us to the end of the actual what was ECTRIMS.
Yeah.
It was very active this year.
Yeah.
So there's a lot to talk about, and we've just selected what our audience wanted us to pick out from
Yeah.
before. Let's have a look at our live chat and see if there is any comments or questions.
We're okay, I think. But we'll give people an opportunity to do that. I'm sure lots of you are having your tea and your, you know, you can watch us at your leisure. So please do drop a comment, and of course we will come back and answer anything you have. And hopefully we will see you again. So we'll say arrivederci, I guess, and it's in Milan in 2023.
Yeah, I was wondering why you were saying that. But
Yeah.
yes, so the next ECTRIMS is combined with ACTRIMS,
Yeah.
isn't it?
Yeah, so it'll be even
so that's
bigger.
the American MS Society meeting. So that will be held in Milan next year.
Yeah.
So looking forward to that. So thank you for joining our session today. I hope you enjoyed the live hangout, and I hope to see you again, hopefully next year, where myself and David will update you on what was reported.
Yeah. Okay, so thanks very much for joining us.
Thank you. Bye-bye.
Bye-bye.